Hi, I'm Stephen Bruce. I run the Academy of Physical Medicine, and here's 45 minutes of free CPD for you. This is just an example of what we do. We run a free session every month, along with 70 plus hours of live learning with others CPD every year. If you'd like to see more, click the link in the info section below the video, and that'll take you through to our website. Enjoy. Today, I'm talking to Elisabeth Davidson. Now, Elisabeth, we promoted her earlier on. We said she was the Director of Academic Affairs at the Royal College. She's actually responsible for academic affairs for the Paediatric faculty. So apologies if we misled you slightly there. We've got her on to talk about pelvic pain in pregnancy. It's a popular topic. We've done lots on pregnancy in the past, and I know that all of us see lots of patients who are pregnant in clinic, and we quite often we struggle. Elisabeth, welcome.
Thank you very much for having me.
Yeah, it's very kind of you to join us. And yeah, that fantastic Alpen background that you have there suggests that you aren't actually in Scotland, but I know you are. You're up in Inverurie, and
I am indeed. Yeah, it looks like
yeah, well, it's a nice backdrop you got there. You said when I spoke to you earlier this week that there's a reasonable amount of new information coming out through research and so on, and some which you're involved in yourself. Do you want to tell us about what you can?
Yeah, absolutely. I was asked almost 2 years ago to take part in a Delphi process on best practice of care of the pregnant woman, which is a sort of multi-international collaboration between some of the big researchers, particularly in America, but they've asked a lot of people to take part in it. So I saw hopefully the final paper last year, but these things always takes a long time to get published. So I'm hoping that that will be a landmark paper that we will all be able to refer to very soon.
Are you able to tell us anything about its conclusions, or is it too early?
I can't really until it's published, but it's basically setting out what is best practice in terms of examination, in terms of treatment, in terms of investigations for the care of the pregnant woman from a musculoskeletal point of view.
Yeah, I have to say I find it astonishing that, you know, here we are in the 21st century and it takes years for research to actually get published. And therefore, not surprisingly, if you want to change clinical practice in, say, the NHS or another official body like that, it takes a long time to do that, even longer. And except in the case of emergency medicine, you know, the COVID stuff has gone through very, very quickly. But yeah, so what can you tell us then about treating pregnant women?
Well, I actually was very lucky. I've been in practice 26 years, and I ended up seeing lots of pregnant women right from the beginning, and I didn't really feel I had any particular qualifications in it, but I just did the best I could, and then I went back to university after 10 years to do a master's degree in pediatric and pregnancy care, and then discovered that there was no real research. Back when I graduated, evidence-based medicine wasn't even invented yet, so it was just a case of try your best. But now, of course, you know, we really have to try and inform our practice with evidence as best as we can. So I decided to look at the evidence, and yeah, so I did my master's degree back in 2007, and back then there was none really at all. And but I do the best I can, and when you treat pregnant women, you obviously have to modify your techniques. You have to use low force techniques. You have to usually take longer, particularly the further along in the pregnancy that they are. And there's a whole list of complications, particularly red flags, that you must be aware of. And it's very good if you can work with the local maternity care community, but that can be a challenge in itself.
Yeah, we said we were going to talk about pelvic pain, by which I have assumed we're going to talk about pubic symphysis and sacroiliac joints. Is that right?
Yeah, I mean, pelvic girdle pain used to be known as pubic symphysis pain, but it actually encompasses sacroiliac and pubic symphysis, and any pain between the iliac crest and the ischial tuberosities, anterior and posteriorly, and with or without radiculopathy. And you can have pelvic girdle pain out with pregnancy, but it's extremely common. I saw a paper yesterday that quoted 81% of women today report pelvic girdle pain during pregnancy, which is astonishing. And
yeah,
that means that it's common. It's not normal, but it's common.
Right. And, you said you have to modify techniques, and presumably, again, we're talking about, the lack of stability as a result of ligaments which have softened up and so on. And you've talked about red flags. So do you want to elaborate on those?
Yeah, well, you have to be aware of all the things that can go wrong in pregnancy anyway, things like preeclampsia, gestational diabetes. There can be things wrong with the mother, there can be things wrong with the baby. Pelvic girdle pain in itself isn't a red flag, but if it's combined with other things like headaches or swelling or neuralgia, pins and needles, things like that, then it could potentially be an issue that needs medical attention. So you need to really make sure that you monitor a pregnant woman very carefully throughout your treatment of her. Sorry, I forgot about your question. What was your question again?
I don't know, I forgot what my question was.
Oh, red flags, yeah.
Red flags, thank you.
Yeah, so those are probably the main ones to be aware of, but there are loads that that could go wrong.
So how are we going to recognize preeclampsia?
The main thing is sudden onset of severe headaches, hypertension, and edema, facial edema, but also edema of the extremities, so particularly the feet and the hands. I mean, a lot of women get carpal tunnel syndrome, for instance, and get a little bit of swelling in the hands. That's not in itself a big problem, but if you combine with the headaches and the proteinuria, so it's a good idea to invest in the urine analysis sample to have in your clinic to check when she comes in.
Do you just use urine strips, or?
Yes, I do, yeah. And then I always check blood pressure every single time I see a pregnant woman. I think that's essential.
Just as a bit of a refresher, what's going on in preeclampsia?
So basically, it's a vascular issue where the mother and the fetus is at great risk, and mum can actually end up dying, and then so can the fetus if it develops into what's known as full-blown eclampsia, and you start getting, as I say, such elevated blood pressure that she can stroke out, and the baby can die. So it's most common in first pregnancies. It's quite rare to have in second pregnancies, unless it's a different father, but it's something that you need to be aware of.
That's curious. So a different father could provoke it in second pregnancy?
I'm not sure. I was told that by several midwives, so I'm not sure what the reason for that is.
Right. Okay. Do we know, I mean, what are the risk factors for preeclampsia? Who should we be more cautious about?
First-time mums is the main one. Older mums, very young teenage girls can also be prone to it. If you're a smoker, if you're known as a mature mother or a geriatric mother, I think the term is, they're more prone to it. If you are, if there's a genetic history, so for instance, if the mother's own mother potentially had it, that's also one of the risk factors.
Okay. So let's get on to, well, I don't want to sort of lead you down any particular routes, but I mean, what about your treatment and case history taking protocols? How do they differ for pregnant women?
Well, first of all, you have to take a very specific case history, looking at, obviously you have to do all your normal neurological and musculoskeletal examinations, your blood pressure. You do a full examination, but then you also need to look at things like the pregnant abdomen. You have to understand the different stages of pregnancy, what happens in the pelvis. You should really be able to understand what the fetus is doing at different stages during pregnancy. Things like pelvic girdle pain, for instance, just go back to that, tends to occur around about halfway through the pregnancy, but it can be earlier and it can be later on. I would say 20 to 25 weeks is the normal onset. Mm-hmm. Pelvic girdle pain also tends to be an earlier onset in subsequent pregnancies, and it can get worse in subsequent pregnancies, particularly if it wasn't treated. In my own experience, women that have had regular chiropractic care, or osteopathic care for that matter, don't tend to develop it as early as women who have never had care before but present to you as a first-time patient with pelvic girdle. which suggests that there is definitely a huge musculoskeletal component to it. It used to be thought that it was mainly hormonal, but we now think that that is not as big an influence on it. It's not just about the relaxin and the estrogen and progesterone levels. It is multifactorial.
Yeah. I'm going to guess here that you're not going to cure their pelvic girdle pain through treatment, so we are in the business of maintenance care for a lot of these ladies.
Absolutely. Yeah. I mean, it very much depends. Some women, you can manage just seeing them, once a month or every couple of weeks throughout pregnancy. And I've had women that drag themselves into the clinic every day for the last couple of weeks because they felt it was the only way that they could keep going until they had the baby. The doctors tend to say that it is self-limiting, as in, having the baby through the pelvic pain.
That's not much consolation, is it, when you've got 40 weeks of pregnancy ahead of you?
Yeah, because we know that if it's not treated properly, it can lead to things like prenatal, antenatal, and perinatal depression, which obviously can have a huge long-term impact on the mother's relationship to the baby. We also know that there's a small subset of women, it's about 10% of those who suffer with pelvic girdle pain that have chronic, severe, long-term pelvic girdle pain that doesn't resolve after birth. And those are the ones that we need to maybe look after a little bit more and try and recognize so that we can give them a little bit more.
So we've had some interesting talks about chronic pain recently. I mean, what are your thoughts on women who have got this chronic problem after the baby's been delivered?
Well, there's several factors that are influencing. If they've had pre-pregnancy trauma, if they have a job where they do a lot of heavy manual labor, if they have a job that's very sedentary and they're not particularly fit, or if they're obese pre-pregnancy, those are other factors that can predispose to long-term pelvic girdle pain. But there is one other major factor that I think have been overlooked, and that's hypermobility. Because that is something that, I always used to say that every woman is by definition hypermobile when she's pregnant. If you are already of the hypermobile condition, then it can make it much, much worse during pregnancy, to the point where some women end up on crutches or in bed because the pelvis is just not coping at all with the increased loads.
Yeah. Tell me, I've actually had a question about this. It's commonly thought that we shouldn't treat people in the first 12 weeks of pregnancy because it's a risky period. I'm a little bit skeptical about that sort of guidance, not least because we had Stephen Sandler, who's a very experienced obstetric osteopath on the show, and he said actually there are some specific times during pregnancy when a woman is likely to miscarry. And it's not just the first 12 weeks. I think 30 weeks is the most risky period, I think he said.
That's right. I agree. If you look at the research, there's actually nothing at all that suggests that it's dangerous to have manual therapy in pregnancy in terms of miscarriage. There is one old reference, I think, from the early 70s that suggests that in women who have repeated miscarriages, it's probably not a good idea. And I think the main reason is that should that woman have a miscarriage after having seen a manual therapist, the manual therapist is likely to get blamed. It's not that there's no evidence to say that it's the cause of it. It's often just a time link, basically.
Yeah. So often the case throughout medicine, isn't it? We do too much. We base too much on association rather than cause. Salome Olivia has sent in a question asking why diabetes persists after delivery and why the mother might become type 1 diabetic.
I think that has a lot to do with lifestyle, unfortunately. I think women on the whole in the Western world don't necessarily have a good lifestyle. They may think that they do, but when you actually go in and do a nutritional profile and say, well, what do you actually eat? A lot of them tend to have processed foods, high in sugar. And you don't always have time to cook a proper meal when you're having a new baby and you've just given birth. And I think part of the problem is modern lifestyles, basically, more than anything.
Interesting. I refer Salome Olivia back to the talk that I did with Gary Taubes, because he talked a lot about the effect of carbohydrates and sugar on insulin levels. And we don't tend to think of what insulin does other than control blood glucose, but it does do other things. And the evidence which he has come across, and he's done a lot of research, is that if you eat a keto diet, then you are likely to bring your diabetes under control, if not get rid of it, and improve your lifestyle in many other ways as well. But yeah,
that's certainly, that I think is what the research is showing now, because we know that women of a lower socioeconomic standing, if you like, are more likely to not have as good a diet, and also are more associated with both post-baby gestational or gestational diabetes and having it afterwards. So whereas women of a higher socioeconomic standing are more likely to have a good diet. So yeah, I would agree with that.
Yeah. So do you use high velocity techniques during pregnancy?
Nope, I don't. I actually don't do any side posture adjustments after 20 weeks at all. You have a massive surge in relaxin around about 20 weeks, where the pelvis can become quite unstable. But personally, I don't really use high velocity techniques anyway, because I'm hypermobile. I have Ehlers-Danlos syndrome, so I veered away from that type of adjustments and really use low force technique more or less all the way through pregnancy. There's so many good low force techniques that can be applied very successfully, but what the research says is that we should not use high velocity type adjustments in the upper cervical spine in any pregnant woman, simply because of the increase in vascularity. You have almost 40% increase in vascularity in pregnancy, and therefore the risk of having a vascular event also increases greatly. So that's not to say you can't do thoracic adjustments or lumbar adjustments in different ways, but we should not use in the upper cervical spine in pregnancy.
Okay. Hannah has sent in a question saying that she tends to understand pelvic girdle pain as a woman who's had underlying issues that the body is managing to compensate for, but then changes, physical and emotional, during pregnancy tip them over the point that the body can compensate, which results in pain. What do you think about that?
So what's the question?
She's basically saying that pelvic girdle pain is peculiar to women who were managing it perfectly well before their pregnancy, but with all the changes, both emotional and physical, during pregnancy, it then brings that pelvic problem to the fore. So she's saying the problem was there already.
Well, that certainly makes it worse if there was already an underlying problem, but it also depends very much on several factors. It depends on her emotional support, whether she has people around her that can help her. I think part of the problem is a lot of women today think they have to be superwoman, and they have to be able to, work right up until they give birth. They have to not run a marathon, but at least, go and do all the things that is trendy. And actually, you don't need to be superwoman. You need help, especially if you have a lot of pain, or especially if it's your second or third pregnancy. And that's not possible for everybody, especially at the moment. I mean, I've seen a massive increase in women with emotional issues in the last year because of COVID, because of isolation, and not only in pelvic girdle pain, but in headaches and tension. They come in absolutely rigid. So I think that's a big part of it. It also depends on how fit you are pre-pregnancy and how fit you try and keep yourself during pregnancy, which is often easier in the first pregnancy. But if you have a toddler or two, then trying to stay fit is not always easy.
No, I can imagine. Zoe's asked for clarification about diabetes. She says, do we mean type 2 diabetes following pregnancy, because type 1 is not lifestyle related?
Yes, I would imagine that was a question, yeah.
Yeah, I think there's a yes and a no answer to that, Zoe, because type 2 can develop into type 1 diabetes. It can become insulin dependent in some people. So I think that's probably, yeah. So in terms of your examination protocol then, Elisabeth, how do you go about it? Someone comes in with pelvic girdle pain. What tests are you doing?
Well, you have to... I've developed this protocol over the years that is partly based on the European guidelines for pelvic girdle pain, which is a massive 120-page document that was published in the early 2000s. And they named some specific tests that you should do. pelvic provocation pain tests, SLR, active SLR, which I actually think is really cruel. If someone has acute pelvic girdle pain, an active SLR is very harsh to do, but that's one of the tests they suggest. They look at Trendelenburg test, and they also suggest that you do palpation of the long dorsal ligament and the pelvic ligaments. But I tend to do all my standing and walking tests first, and then I have the mum sit down and I do a lot of the upper body musculoskeletal tests. Then I have her prone on a pregnancy pillow, and then finally I turn her over and supine, because you don't really want to have a pregnant woman move too much if she's in pain anyway. So no. I developed this specific protocol that I do. And I've learned lots of different techniques over the years that I find for me works really well. And I've actually designed a form that hopefully we can get published soon, which is partly based on the new best practice guidelines coming out, which incorporates everything that really should be doing if you're seeing a pregnant woman. So hopefully.
And I wanted to be able to share that with our viewers, but I can't until it's published. Oh, we can? I can?
Yeah, absolutely, yeah.
Excellent, brilliant. I'll send that out after the broadcast if you'll let me have it. Thank you.
Yeah, will do.
Super, that'd be really kind. Somebody who's chosen not to give us their name says, what do you think about women who practice a lot of yoga? And is there any truth in the rumor that the cord can unravel and end up around the baby's neck during some postures?
That's a good question. I think that very much depends on what type of yoga you do. I've seen some that do this sort of acrobatic type yoga where you go upside down. I probably wouldn't recommend that in pregnancy, but I always recommend pregnancy for women, because I think in the last sort of 10-15 years that has blossomed and built to a tremendous point where it's available almost everywhere, and there's a lot of really good pregnancy yoga courses. So, but that's more gentle type yoga. So,
I tell you what, Elisabeth, it sounds to me a little bit like that you get blamed in the first 12 weeks of pregnancy if something goes wrong. How on earth can anyone know that it was the yoga that caused a cord to go around the baby's neck? It's, you know, but I'll bet the yoga practitioner gets blamed, or yoga gets blamed.
Well, that's right. I've never heard that actually. So that's an interesting point. I mean, a baby will twist and turn and move and flip, and yeah, sometimes they do inveigle themselves in the cord, and sometimes they don't. And I don't think we can predict that, to be honest. And I've actually never heard it being associated with yoga, but yeah, sure. I'll look into it.
Now, it's Pip has now sent in. Could you please talk about some of the techniques you find useful in treating pelvic girdle pain? Okay. People want to know what they do when they get their hands on.
Yeah. Well, I'm obviously a chiropractor, so I learned a technique many years ago called sacro-occipital technique, which is a very whole body, cranially based dural technique, which is very low.
Sorry, the osteopaths will know it as craniosacral technique. So it's I'm, as far as I'm aware, they're almost identical. So they'll understand what you're talking about.
I've done craniosacral therapy as well, and it is quite similar. So that's what I tend to use. I will use activator, which is a little tool that we have. I don't know if osteopaths use that. And I use blocking quite a lot. Blocking, yeah, pelvic blocks. You know, if you have, say, a pelvis that's slightly torsion because of muscular imbalance and ligament imbalance, then you block them so that the pelvis basically untorques by itself with a weight on top of it. It's very useful, and that's part of SOT. What else do I use? I use some. I don't do needles, but the clinic I used to have, we had an acupuncturist who specialised in pregnancy care, so I would often send them for acupuncture. That's actually got really good research behind it, and probably more than just about anything else. And then I would do quite a bit of soft tissue work, and work with the woman with things like insoles and making sure her posture was correct. I would talk about things like optimal fetal positioning, particularly towards the end of the pregnancy. Talk about sitting upright and forwards, like on a ball, rather than sitting on an office chair. So it's quite diverse. You know, it depends on the woman's ability to do what we'd like them to do. But I have a huge arsenal of different techniques for different people.
Do you find trigger points have a role to play in treating pregnancy?
Oh, absolutely. Yeah. They don't like them particularly much, but they are extremely helpful. I find a lot of the pelvic girdle pain can be eased greatly if you focus on particularly the muscles, obviously, of the pelvic girdle. So, you know, your glutes, your iliopsoas is extremely important for the pelvis stability. And that's tied in with the hamstrings, of course, which tend to be extremely tight in pregnancy. And the hamstrings have fibers that go into the sacrotuberous and the sacrospinous ligament. And so if you have a lot of pain over there, you know, you need to look at the hamstring. And the adductors can get exquisitely painful, particularly if they've got pubic symphysis pain. I don't really do any intra pelvic work as such. You know, I work with a local physiotherapist who specializes in that. But I do some gentle, what we call pelvic floor release, which is a craniosacral therapy technique. And then we talk about what they can do to help themselves. I'm very much into giving the patients exercises to do at home.
Right. Okay. A little while ago, you said after 22 weeks, you don't treat patients side lying. Why?
Because you can be careful. If you're not careful, you can torsion the pelvis way too much, and therefore the ligaments, and especially the round ligament and the broad ligaments, and you don't really want to do that. And also because I find it difficult to stabilize, you know, a large pregnant belly on a bench, basically. So I used to, but I just find it's uncomfortable for her. And I mean, you can't do it provided you support the belly with a pillow underneath, but you just need to make sure you don't torque too much. And I just find it easier not to do it. It doesn't mean you can't do it, but I just personally don't like it.
Yeah, I don't think any of us would want to do something which had the chance of exacerbating the problem, would we? Gina has asked whether you recommend the use of support belts in pelvic girdle pain.
For some women, that's absolutely a necessity, and there's some really good ones. There's Sorolla belt. There's some called belly bandits. I don't know if you've seen them. They're very keen on selling them, but they're actually super. And I had sort of 2 or 3 that I bought and just lend out to patients because some women absolutely need them. It's ideal if you can do without them, because obviously they tend to take the strain that the body's own should be able to do. But if her body can't cope with it, then that can be a great help for her. So. Right.
Okay. Thank you. Somebody's taking us back to your comments about increased vascularity and stroke. They haven't given me their name, but they've asked whether pregnant women are prone to clots. They say due to rhesus factors, but for any reason, I'd have said.
They are more prone simply because of the increased vascularity. Yeah, so that is something that needs to be taken into consideration when you're doing your risk assessment.
So it's not a question of them suddenly becoming more clotty, it's just that there are more veins and arteries in which clots might occur.
Yeah, and also you've got suddenly a huge weight gain. Some women take getting pregnant as a license to eat, so they can put on 4 stone. I've seen it's not uncommon. They don't need to, but they do. And some women do tend to put on a lot of, or rather retain a lot of fluid. So that puts an enormous pressure, particularly on the lower limb vascularity as well. So yeah, definitely need to be mindful of that.
Okay. Jeff has asked whether it's fair to say that you're actually aiming for pain management rather than cure in the PGP of the 3rd trimester.
I would say so. Yeah.
Well, I guess, you know, given that the alternatives are, there isn't anything better, is there? Nobody's going to cure the pain. It's not unreasonable to do pain management.
No, because in terms of what the medical profession has to offer, I mean, they used to offer support belts and crutches and painkillers, but a lot of women are not happy about taking medication during pregnancy, and a lot of them are unsafe. So they tend to rely on paracetamol, you know, unless they're on prescription drugs.
Sorry, when you say a lot of them are unsafe, a lot of what are unsafe?
A lot of medications are unsafe in pregnancy.
Right. Okay.
Things like opioids, for instance, they are really not advised to be a first-line treatment for.
But presumably they're not going to be prescribed by the GP, are they?
You'd be surprised.
Yeah, you're right. I would. Tio has sent it. Tio, I hope I'm pronouncing your name correctly. Tio says, if you find the muscles to be tight, would you recommend stretching exercises to a pregnant patient who's already increasingly mobile?
Yes, and this is where you have to really look at the woman as a whole. Why are certain muscles tight? Is it because she's sitting in an office chair all day, in which case the hamstrings are likely to be tight? Or is it because they're trying to compensate for the pain? So you need to try and figure out where is that. Is it a compensatory muscle tension, in which case you need to find out, you know, the original factor why it's tight and correct that. So I find they do incredibly well with a combination of stretching and just gentle cardiovascular exercise, whether it's swimming. Well, of course you can't do that at the moment, but it can be difficult for them to walk sometimes because of the pain. So I always prefer things like water exercise, because that also has a lot of good research behind it, and things like pregnancy yoga that we talked about earlier.
Right. Okay. Interesting that there is research around this. I wonder why there's so much research around relief of pain in this circumstances as opposed to other.
Yeah, it's because the physios have taken a great interest in this, and there's been some fantastic research actually looking at different aspects. An enormous body of evidence, particularly by a Norwegian physio called Britt Stuge, who's also published, if I can plug that, a fantastic outcome measurement questionnaire. It's a 25-point questionnaire that I've been using in practice for 10 years nearly. No, it was published in 2011. And I wish we could get everyone in the country who see pregnant women to use this questionnaire, because it would produce an enormous amount of research that would be good. So it's Britt Stuge, and if you Google pregnancy outcome questionnaire.
How do I spell Stuge?
Stuge. I can send you that paper if
Please,
you like.
thank you. Because one step towards that is if I can just send it out to people, and then hopefully they can choose to use it if they're so inclined.
Yeah.
On Saint, again, I hope I'm pronouncing your name correctly. She asks, have you ever had experience turning a baby? And are you allowed to do that where you are? And what are your thoughts about it? I tell you what, before you answer that question, all three of my children were breech births, and I think my ex-wife went to an acupuncturist for moxibustion for all of them, because moxibustion was meant to encourage them to turn. Didn't work at all. But they're all born perfectly healthy. So.
Well, we don't turn babies. That's an obstetric maneuver. What we do is we correct the biomechanical imbalances that may be in the pelvis and the spine, which creates optimum space for the baby to maneuver in. And in some cases, the baby will actually turn itself. So I just want to make that really clear that we do not turn babies. That's illegal. So you have to be really careful how you phrase it. Having said that, I have seen many babies turn themselves after treatment over the years.
Right. And do you think, I'm guessing you do imagine that the treatment contributed to that?
Oh, sometimes it's almost within 5 minutes of treatment. I always make the mum get up and walk around the room to try and ensure that the treatment will hold. And sometimes she goes, oh my goodness, oh, something's happening. It can be as quick as that. Or I've seen quite a number of workshops, for instance, when I've been teaching courses, we've had a few pregnant participants, and the baby has turned later that day after 10 people were working on this poor woman. So yeah, it can be as quick as that. It doesn't always work, there are reasons why. Either the cord can be short, or like you said earlier, the cord can be around the neck, and then no amount of treatment is going to turn that baby. But I can't actually say the amount of percentages that I've seen where it's happened, and there's not a lot of good research on it. There's a couple of papers by the people in America that teach the Webster technique, but they're not really they're not efficacy papers. They're just outcome measurement papers, and they do show something like, I think it's 75% improvement in positioning after treatment.
That raises an interesting question, actually, doesn't it? I mean, someone with your great knowledge about treating pain in pregnancy and your great experience about treating pregnant patients, what are you allowed to say on your website or in any other advertising about what you can do for the pregnant patient?
Very little, unfortunately. we've been trying to lobby the ASA for a number of years, and we managed to get them to change the wording a few years ago. The Royal College was very much involved in that lobbying, so that we can now say that we treat pregnant women for the musculoskeletal discomforts that they may experience. That's it. No conditions. Don't mention pelvic girdle pain. You know, don't mention any conditions as such. And that's very frustrating, but it's the law of the land, and we just have to stick to it.
Yeah, it's interesting. We had a very interesting talk with the ASA ages and ages ago, and I think it was Jonathan Field from the RCC was on the panel with a load of others. And at that time, chiropractors weren't even allowed to say they could treat sciatica. You know, but osteopaths were, and you think, well, what the hell do we suddenly know that chiropractors don't know about treating sciatica? I mean, I know the ASA has to act in accordance with you know, the available evidence and so on, but it's sometimes it's a little bit frustrating, isn't it?
It is very frustrating, and I don't know really why, but the bottom line is, until we produce the research that shows efficacy, we have to stick to the guidelines.
Of course, yeah. And actually, it's very easy to find out what those guidelines are, because you can, well, actually, we've sent them out before from the academy, but you can go to the ASA and you can look at what what they say chiropractors are allowed to say and what osteopaths are allowed to say, and they are different, weirdly.
Yeah, I actually contacted the ASA a couple of years ago because I wanted to produce a leaflet on pregnancy, and I had a lot of to and fro and backwards and forwards, but eventually they accepted the wording that I put in the leaflet, so I'm more than happy to share that as well with you.
Oh, please, that would be so kind.
Yeah, and then
brilliant.
People can at least know that has been accepted by the ASA. It's very vague and very bland, but I think it's a nice little leaflet.
Yeah. Okay. Pippa sent in another observation, and she's put a kiss at the end of it, so I'm going to read it out. It says, optimal fetal positioning can help encourage babies to turn into the right positions. Well, I thought optimal fetal positioning is the right position, isn't it?
Yes.
But do you know what that means? What does that actually mean, optimal fetal positioning?
It was a term that was coined by a midwife called Jean Sutton, an Australian midwife, about 20 years ago, I think. And there is actually quite a bit of research behind it now. There wasn't back then, but now we know that if the baby is not in the right position, as in occiput anterior, which is the ideal position, if the baby has the occiput the wrong way, then the labors are more painful and much longer. And normal first-time labor could be anywhere from 2 to 24 hours. But if the baby's in the wrong position, it can be up to 48 hours or even longer. And we also know that if the baby's in the wrong position, you're more likely to get intervention, to be induced, to have C-section, and with all the cascade of things that can then cause. So, and I think the medical world has become aware of this much more, particularly in the midwifery teams at the hospitals. So they are aware of this, and they are more happy to work with what we do and understand what we do and how that can help. So it's a really interesting phenomenon. There's, I was taught initially by an American chiropractor called Carol Phillips, and her work has since been turned into an amazing, what's it called? Spinningbabies.com. I don't know if any of you have heard of Spinning Babies.
Oh, I think I have actually, yeah.
Yeah. And there's courses on that all over the country now, and it's about how to basically, the woman, for us as practitioners, to help not just chiropractors and osteopaths, but yoga teachers and midwives as well can do this course, learning how to help the baby turn. So that's really been fascinating to watch that develop over the years. And
interesting that the person running the spinningbabies.com is allowed to say that's what they're doing, but we can't.
I know, it's not fair, is it?
It's not fair. No, life isn't fair.
But they're not a registered practitioner, so.
Apparently there's a debate going on the Vimeo team, because we have two teams watching this, Facebook and Vimeo. There's a debate going on the Vimeo team about which positions are best to treat, especially in late stage pregnancy. And I know we talked about it before, but could you just recap and confirm what are the best positions?
To treat the woman during treatment? Yeah. Well, I tend to predominantly treat in the prone position. I have a specialized pregnancy pillow that she can lie in comfortably. you have to be careful not to keep her in the supine position for too long. And if you do have her in the supine position, you really should try and elevate her upper body by about 30 degrees, because otherwise she's likely to feel faint or actually faint. Basically, because if the baby's very big or towards the latter stages of pregnancy, the baby can lie on her aorta, have her in the supine position. So you should try and avoid that for as long as, you know, or a minimal amount of time as possible. So I prefer to do everything I need to do supine first, and then at the very end I'll have her supine and do a little bit of neck and cranial work, and then get her up and walking as quickly as possible. Now, if you can't get her supine, or if you don't have a pregnancy pillow, then you can have her in side posture. As long as you ensure she's got a pillow between her knees, and so that her spine is nice and straight and not torqued or torsioned at all.
Do you prefer one particular side? Because there is a problem of potential vascular compromise, isn't there, in side lying?
Yes, and we also, the midwives will encourage a woman to sleep on her left-hand side towards the end of the pregnancy, because we really want the baby to lie on her left-hand side to get into optimal positioning. Because basically the uterus has a little bit of dextral rotation built into it, so the baby will come out in a corkscrew fashion. And if you have her on the right side, it's more difficult for the baby to get into the right position. So yeah, left side would be preferable.
Okay. I mean, you've talked about some interesting cases just there. I mean, I should imagine with your experience, you've got some quite stunning success cases that you might want to tell us about. Give us some encouragement that, you know, we can make a big difference with this, Elisabeth.
Well, I had a woman that probably shouldn't have had more than 2 babies, but I saw her through her second, third, and fourth pregnancy, and she had the most horrific pelvic girdle pain that you can imagine. She's very tall, very, very thin, and she produced 10-pound babies every single time. And she had them quite close together. She had about 2 years in between all of them, which is also one of the things that can predispose to pelvic girdle pain. And we managed.
Women don't learn, do they?
Amazingly, you forget. Once that baby's on your belly, you forget how sore it was. Yeah. So she was one of those people that the latter weeks of each pregnancy, I had her in almost every day or every other day. But we managed to get every single baby full term, because they did actually threaten to induce her early because she was in so much pain and the baby was getting a little bit distressed. But she stuck with what we did. And just coming back to what we were talking about earlier with the vascularity and the miscarriage, I had a woman who I knew had Ehlers-Danlos syndrome. She was very hypomobile, so we were very careful in how we were treating her. We didn't do any manipulation whatsoever, because that's contraindicated in Ehlers-Danlos. So we just purely did soft tissue work. And after she had been in, this was her second pregnancy as well, she'd been in to see one of my colleagues around about 14 weeks. And 2-3 days later, she started spotting. So she was very, very concerned that the treatment might have caused this. And she called me up and asked to speak to me. And I explained that actually spotting around about that time is not uncommon. And that I didn't think it had anything to do with what we'd done, because I knew that we had been extremely gentle, if you like. Not that I think chiropractic or osteopathy could cause that. But I encouraged her to speak to her midwife and just to get reassurance that everything was okay. And she went and she had another scan and everything was fine. And we managed to see her all the way through her pregnancy as well. And she was thankfully after the...
Just want to stop you for a second, Elisabeth. Justin, have we got the right picture going out? Right, carry on, please, sorry.
Yeah, so I think those are probably the ones that I find not pride in, but I'm really happy that I've made their life a lot easier and alleviated some of their fears and some of their concerns. And then I had another lady that had such a bad experience in her first pregnancy. She almost died. I saw her all the way through her pregnancy, and she was responding really well. But the baby just wasn't coming out. I think this baby was wrapped up in the cord, and so she ended up with this whole cascade of intervention, unfortunately. And she came back to me afterwards, and she says, "I'm not having any more babies. I'm too horrific. But thank you so much for what you did." So,
bottom line is we can actually make a big difference to the process, can't we? And we're just about at the end of our time. One quick question from Ben. Ben says, do you recommend any particular pregnancy pillow? He apparently uses the Belloost, but as he's never been pregnant, not yet anyway, he just wanted to check for comfort purposes.
Yeah, well, I've used 3 different ones over the years. The developer of Belloost sent me one kindly to try out on our patients when she was just producing it, and hands down, that is the one that the women that I see love more than any of the pillows I've tried. So I would highly recommend it. I mean, there are good ones too, but that's exceptionally good. It's really well designed because it's been designed by, a manual therapist. So.
Yeah. Elisabeth, that's been great. Thank you. We've had lots of people thanking you for this. Monica in particular, I've got one comment from here saying this has been a fantastic talk, and we should thank you very much. I'd really like to know the results of that Delphi study that you've been involved in, when we're allowed to know it eventually. And if you can share those other resources with me, I'll make sure that all of our viewers get hold of those, and we'll put them on the website with the recording, so that hopefully we can improve not just pregnancy care, but we can improve the research behind it as well. Thank you.